For this lecture, we'll be looking at invertebrate pests and ectoparasites. These are the arachnids, such as mites and ticks. The learning objectives are to identify and describe arachnids, including mites and ticks. This is based on their morphology, their life cycle, distribution, associated human diseases, signs of infestation, and their control and prevention. The objective of this lecture is also to describe the following human diseases, which are transmitted by mites and ticks. These diseases are scabies, Lyme disease, and tularemia, based on their clinical symptoms, epidemiology and transmission routes, laboratory diagnosis, treatment, and control and prevention, and to also list other human diseases that are transmitted or caused by ticks. So, what are arachnids, and why are they different to insects? Well, they have 4 pairs of legs and not 3, and this includes spiders, ticks, and mites. An arachnid has a cephalothorax and not a separate head and thorax. It also has simple eyes and not compound eyes. Ticks and mites are actually related. Let's look at the first disease that is transmitted by arachnids, and this is by the human itch mite. The disease is called scabies. Scabies is a disease that causes a lot of itching. The itching can be mainly at night. If you get scabies for the first time, you will likely be asymptomatic for 2 months, and then you'll start itching, and there will be signs that you have this parasite. Subsequently, if you have cleared the infection and then get it again, the itching will be a lot faster, usually 1 to 4 days after exposure. This is because you get sensitized to the proteins from the mite and also their excrement. The symptoms are having a skin rash with very small pimple-like papules, and this is found mainly on the skin folds, that is, around the wrists, the back of the elbows, and around the waist. Also, there might be very tiny serpentine lines on the skin. This is where the female scabies might make their burrows. This is a picture of a scabies burrow. It is highly magnified and is a view of the burrowing trail of a scabies mite. The large scaly patch on the left was caused by scratching and marks the mite's entry point into the skin. The mite has burrowed to the top right, where it can be seen as a dark spot at the end. There is no scale on this picture, but in real life, you will not be able to see the burrows as clearly. You will, however, be able to see the large scaly patch, since the person has scratched this area quite badly and there is some scarring. So the scratching that results may cause skin infections from Staphylococcus or Streptococcus, and because of this, it may lead to kidney infections and kidney inflammation. A form of scabies that is most serious is called crusted or Norwegian scabies. It's a very severe form of scabies that is found mainly in the elderly and immunocompromised individuals and those with neurological disorders. With crusted scabies, itching is actually absent. And so, because of the lack of itching, the diagnosis is delayed and treatment is also delayed. This results in heavy infestations, and if a patient is admitted with crusted scabies, it can become a major problem in long-term care homes and hospitals because the person is highly infectious and will likely cause an outbreak in these facilities. This is a picture of the hands of a case of Norwegian scabies. Unfortunately, this individual is homeless and has AIDS. Notice the severe scaliness on the hands and around the wrist. All the skin crusts are full of scabies mites. When the crusts fall off, caregivers and healthcare workers that are in close contact are at very high risk of getting scabies if they don't use PPE. The scabies mite is an ectoparasite that creates burrows in the upper skin layer. Adult scabies mites are less than half a millimeter long in size. That's tiny, and mites can only be viewed in detail using a microscope. Scabies mites have a 4-stage life cycle, which include the egg, larvae, nymph, and adult stages. Female mites can live for up to 2 months in skin burrows. and lay 2 to 3 eggs a day. Eggs hatch after 3 to 4 days, and larvae migrate to the skin surface. After 3 to 4 days, they develop into nymphs in short burrows called molting pouches. Nymphs molt to become mature adults and mate. Male mites are rarely seen. They wait in temporary shallow pits before locating females and mating with them in their molting pouches. They only mate once. Impregnated females remain fertile for the rest of their lives and wander around the skin surface till they find a suitable site before making the long serpentine burrows to lay their eggs. They remain there permanently for the rest of their lives. Scabies can be found worldwide in all social classes. Generally, outbreaks occur in crowded conditions, in childcare facilities, long-term care homes, and prisons. Scabies can be transmitted through direct contact, and that is with an infested human being, either through sexual contact or prolonged skin-to-skin contact. It can also be transmitted indirectly through sharing clothing, bedding, or towels of heavily infested humans, especially those with crested scabies. Diagnosis is really looking for the characteristic pimple-like rash or burrows, and through skin scrapings to look for the mites, and using microscopy to confirm that the mites are present. Scabies can be treated with a permethrin cream at 5% concentration, which is 5 times higher than the 1% permethrin used for head lice. It should not be used for babies below 2 months of age. The cream should be applied to all areas of the body from the neck down to the toes for adults, and on the head and neck as well for infants. Wash off the cream after the recommended time and wear clean clothing after the treatment. Although these look like prevention strategies, the steps described will help to eliminate any infestations that are present. They're very similar to the ones for other ectoparasites such as head lice, so I won't read them out. But I need to alert you to the itching that might continue for a few weeks after treatment. This is due to the hypersensitivity to mite proteins in excrement, so a second course of treatment should only be administered if the itching persists after 2 weeks to a month, or if new burrows or rash appear. In order to prevent reinfestation, all household members and any close contacts within the preceding month should be treated at the same time. This includes sexual contacts and those who have had prolonged direct skin-to-skin contact with the infested person. Institutional outbreaks can spread very quickly and are really difficult to control. They may also spread beyond the facility to the community. Outbreak response really depends on the extent of the spread, the type of scabies. Obviously, crested scabies or Norwegian scabies requires more aggressive responses. When a scabies outbreak occurs in an institutional setting, several control measures need to be in place. This includes surveillance for new cases, provision of on-site diagnostic services, treatment of all cases, especially staff, their family, and close contacts. Infection control has to be present with PPE for healthcare workers who are in close contact with the case and avoidance of skin-to-skin contact. The room where the case was located needs to be cleaned thoroughly after they leave, and their bedding and clothing washed and dried using the hot cycle. It is necessary to notify the Public Health Unit and any other institutions that have reported infested or exposed patients. In Ontario, under the Occupational Health and Safety Act, OHS, the Ministry of Labour, and the union have to be notified, and WSIB claims submitted for any staff members who are affected. An epidemiological study needs to be carried out as well. With crested scabies outbreaks, the cases and contacts need to be treated rapidly and repeatedly if required. The patient with crested scabies should be isolated and assigned dedicated staff. Any visitors should be limited and need to use PPE. The room should be cleaned regularly to remove skin crusts. Thorough cleaning and vacuuming is essential when the patient leaves.